My son called from his hospital room. "Dad, the doctor is refusing to treat me because he says I'm faking my symptoms, and the nurses agree with him." When I entered the room, the doctor's dismissive expression crumbled, and he whispered, "Dr. Blackwell, head of the medical board, I didn't realize he was your son." The call came at 3:42 p.m. on a Wednesday afternoon, while I was reviewing disciplinary cases in my office on the 7th floor of the State Medical Board headquarters. My son Ethan's name lit up my phone screen, and I almost sent it to voicemail because we had a standing rule about not calling during work hours unless it was an emergency. But something made me answer on the second ring. "Ethan, what's wrong?" His voice came through thin and strained, fighting to stay steady. "Dad, I need you to come to Memorial General right now. I'm in the emergency department and they're refusing to treat me. The doctor says I'm drug-seeking, that I'm faking everything, and the nurses are acting like I'm wasting their time. But Dad, something's really wrong. My abdomen hurts so badly I can barely move, and I keep throwing up, and they just keep telling me to calm down and stop being dramatic." My chest tightened. Ethan was 23, worked as a software engineer, had never been in serious trouble, never had substance abuse issues, was the kind of kid who felt guilty taking Tylenol for headaches. The idea that he was drug-seeking was absurd. "I'm on my way. Don't let them discharge you. Tell them your father is coming and he's a physician." There was a pause. "I tried that. They don't believe me." I'd been head of the State Medical Board for 6 years, appointed after spending 18 years as a trauma surgeon at County Medical Center and another 5 years in Medical Education Administration. The board was responsible for licensing physicians, investigating complaints, enforcing standards of care, and disciplining doctors who violated professional or ethical guidelines. I'd overseen hundreds of cases, from minor infractions to serious malpractice, and I had a reputation for being thorough, fair, and uncompromising when it came to patient safety. Doctors across the state knew my name because I'd made it my mission to hold the profession accountable. But right now, none of that mattered. Right now, I was just a father whose son was in pain and being ignored. I grabbed my jacket, told my assistant to cancel my afternoon meetings, and drove to Memorial General Hospital, a large teaching facility on the north side of the city. It took me 23 minutes to get there through traffic, and every minute felt like an hour. I kept replaying Ethan's words, refusing to treat him, calling him a faker. I'd seen that attitude before in complaint files, the dangerous assumption that young patients complaining of pain were automatically drug-seeking, the dismissive arrogance of physicians who'd stopped listening to their patients. Memorial General's emergency department was crowded when I arrived at 4:18 p.m., the waiting room filled with people in various states of distress. I went straight to the intake desk and told the receptionist I needed to see my son, Ethan Blackwell, who'd been brought in earlier. She checked her computer, frowned, and said he was in Observation Bay 12, but that only family was allowed back. "I'm his father," I said. She gave me a visitor badge and buzzed me through the secure doors. The emergency department was a maze of curtained bays and monitoring equipment, alarms beeping, staff moving with purposeful efficiency. I found Bay 12 at the end of a hallway, the curtain partially open. Inside, Ethan was lying on a gurney, pale and sweating, one arm wrapped around his abdomen. He looked up when I entered, and the relief on his face was mixed with something else. Fear. "Dad, thank God." I went straight to him, put my hand on his shoulder. "Tell me what happened." He'd woken up that morning feeling fine, gone to work, but around noon started experiencing severe abdominal pain in his lower right quadrant. At first, he'd thought it was food poisoning, but the pain got progressively worse, sharp and constant, and he'd started vomiting. His co-worker had driven him to Memorial General around 2 p.m. The triage nurse had taken his vitals, noted his complaints, and sent him to a bay to wait for a doctor. When Dr. Lawrence Kemp finally showed up around 2:45, according to Ethan, he'd barely looked at him before asking how much pain medication he was looking for. Ethan had tried to explain his symptoms, the location and intensity of the pain, the nausea, but Kemp had cut him off and said that abdominal pain in young men was almost always exaggerated, that real surgical emergencies presented differently, and that Ethan's vitals were stable, so there was no cause for concern. Kemp had ordered basic lab work and told Ethan to wait. That was over an hour ago. The labs had come back. Ethan had seen the nurse look at them, but no one had come back to discuss results or examine him further. I felt my hands curl into fists. Lower right quadrant abdominal pain in a young adult, sudden onset, worsening over hours, accompanied by vomiting. Those were classic symptoms of appendicitis, one of the most common surgical emergencies. Any competent physician should have recognized the presentation immediately. "Has anyone done a physical exam, checked for rebound tenderness, evaluated the pain?" Ethan shook his head. Kemp barely touched me. He pressed on my stomach for maybe 5 seconds and then said I was being dramatic when I told him it hurt. I pulled out my phone and was about to call the charge nurse when a man in a white coat appeared at the curtain entrance. He was in his early 50s, average height, with thinning hair and the kind of expression that suggested he was perpetually annoyed by something. His name badge read, Dr. Lawrence Kemp, Emergency Medicine. He looked at me with obvious irritation. "You can't be back here. Family consultation happens after evaluation is complete." I stayed exactly where I was. "I'm Dr. Blackwell. This is my son Ethan. I understand you've been treating him." Kemp's expression shifted slightly, a flicker of something I couldn't quite read, but he maintained his dismissive tone. Your son presented with vague abdominal complaints. His vitals are stable, his labs show mild leukocytosis, but nothing concerning. He's likely dealing with gastroenteritis or anxiety. We see this kind of presentation constantly from young men who want narcotics. The casual accusation made my blood pressure spike. My son doesn't use drugs. He's never had substance abuse issues. And mild leukocytosis with right lower quadrant pain is consistent with early appendicitis. Have you ordered imaging? Kemp crossed his arms. Imaging isn't indicated for every stomachache. We don't have unlimited resources. And I'm not going to waste a CT scanner on someone who's probably going to feel better in an hour. I took a breath, trying to maintain professional composure, even though I wanted to grab Kemp by his coat and shake him. Doctor, appendicitis is a clinical diagnosis, but imaging can confirm it and rule out other pathologies. Given the presentation, at minimum, you should be doing a thorough abdominal exam and considering surgical consultation. Kemp's face reddened. Are you trying to tell me how to practice emergency medicine? I'm telling you to properly evaluate your patient. The tension in the bay was thick enough to cut. Kemp glared at me, and I could see him making calculations, deciding whether to escalate or back down. He chose escalation. Your son is displaying classic drug-seeking behavior. Vague pain, demands for imaging, insistence that something serious is wrong despite reassuring vitals. I've been doing this for 20 years. I know the difference between a real emergency and someone fishing for prescriptions. I felt Ethan tense beside me. I'm not drug-seeking, he said quietly. I'm really sick. Kemp ignored him, keeping his eyes on me. If you're not satisfied with the care he's receiving here, you're welcome to sign him out against medical advice and take him somewhere else. But I'm not ordering imaging, and I'm not calling surgery for what is clearly a non-emergent situation. The dismissiveness, the arrogance, the complete lack of clinical judgment, it was exactly the kind of dangerous medicine I spent my career fighting against. But I also knew that revealing my position as head of the medical board right now would likely make Kemp defensive and potentially create more problems. I needed to document what was happening, get other people involved, and protect Ethan. I want to speak to your attending physician, I said, and I want the charge nurse to come evaluate my son's current condition. Kemp smirked. The attending is in a trauma resuscitation. She's not available to hold your hand because you don't like my medical judgment. And the charge nurse is going to tell you the same thing I am. He turned to leave, then paused. Your son can wait here for another hour or two. If his symptoms persist, we'll reevaluate. If they resolve, we'll discharge him with instructions to follow up with his primary care physician. Either way, he's not getting narcotics. He walked away before I could respond. I looked at Ethan, who was blinking back tears of pain and frustration. This is insane, he said. I told them I don't want pain medication. I just want someone to figure out what's wrong. I pulled over a chair and sat down next to the gurney. I'm going to fix this. But first, I need to examine you myself. Is that okay? He nodded. I washed my hands at the sink in the corner of the bay and then carefully palpated Ethan's abdomen. The moment I touched his right lower quadrant, he winced and tried to pull away. Clear tenderness at McBurney's point. I checked for rebound tenderness, pressing gently and then releasing quickly. Ethan gasped. Positive rebound. I checked for referred pain by pressing on his left side, and he reported pain on the right. Rovsing's sign, positive. These were textbook findings for acute appendicitis. Ethan, I think you have appendicitis. Your appendix is inflamed and needs to be removed surgically. Dr. Kemp's assessment is wrong, and frankly, it's dangerously negligent. I pulled out my phone and called Richard Alvarez, a surgeon I'd worked with for years before moving to the medical board. He was chief of surgery at County Medical Center across town, but he'd have colleagues at Memorial who could help. He answered on the third ring. Richard, it's David Blackwell. I need a favor. My son is at Memorial General with what I'm certain is acute appendicitis, but the emergency physician is refusing to order imaging or call surgery. Can you contact someone at Memorial and get him proper care? Richard's voice went sharp with concern. Which emergency physician? I looked at the name badge I'd noted. Dr. Lawrence Kemp. There was a pause. Kemp. Yeah, I've heard complaints about him. Arrogant, doesn't like being questioned, has a reputation for undertreating patients. Give me 10 minutes. I'll call Angela Park. She's chief of surgery at Memorial. She'll get your son taken care of. I thanked him and hung up, then turned back to Ethan. Help is coming. Hang in there. But even as I said it, I could see his pain was worsening. His face had gone gray, and sweat was beading on his forehead despite the air conditioning. Dad, I feel like I'm going to throw up again. I grabbed the basin from the bedside table and held it while Ethan retched, bringing up bile and saliva. Nothing solid, because his stomach was empty. When the spasm passed, he collapsed back against the pillow, trembling. I checked his pulse at his wrist. Fast, around 110 beats per minute. His skin was clammy. These were signs that his condition was deteriorating, that his appendix might be progressing from inflamed to ruptured, which would turn a straightforward surgical problem into a life-threatening emergency. I went to the nurse's station and found the charge nurse, a woman named Linda Forsyth, according to her badge. "Excuse me, I need someone to reassess my son in Bay 12. His condition is worsening." She looked up from her computer with the practiced patience of someone who dealt with anxious family members all day. "The doctor has already seen him. If there's a change in his condition, we'll notify Dr. Kemp." I kept my voice level. "His heart rate has increased to 110. He's vomiting. He has clear peritoneal signs, and he needs immediate surgical evaluation. I'm requesting that you page the attending physician or call a surgical consult." Linda's expression cooled. "Sir, I understand you're concerned, but we can't call specialists every time a family member disagrees with the physician's assessment. Dr. Kemp has evaluated your son and determined that watchful waiting is appropriate. If you're not satisfied, you can request a transfer to another facility. But that will require your son to be medically stable, and you'll need to arrange private transport." The bureaucratic wall was infuriating, but I'd worked in hospitals long enough to know how the system operated. Everyone deferred to the attending physician. Nurses, even experienced ones, rarely overrode a doctor's orders unless there was a clear emergency. And Kemp had framed Ethan's case as non-emergent. My phone rang. Richard Alvarez. "David, I talked to Angela Park. She's sending one of her residents down to the ED to evaluate Ethan. Should be there in the next few minutes. But she also told me something you should know. Kemp has a history of complaints. Patients who felt dismissed, missed diagnoses, delayed treatment. Nothing that's resulted in formal discipline yet, but the hospital administration has apparently counseled him multiple times about his bedside manner and clinical judgment." I felt cold anger settle in my chest. "How is he still practicing?" Richard sighed. "You know how it is. Documentation issues, he said she said situations, no clear pattern of harm that would justify restriction of privileges. He's technically competent when he wants to be, but he's got blind spots and an attitude problem. The hospital knows it, but they're short-staffed in the ED, and they're reluctant to lose a physician." This was exactly the kind of systemic failure I investigated at the medical board. A doctor with known problems, multiple complaints, but allowed to keep practicing because the institution prioritized staffing over safety. "Thanks for the heads up, and for calling Angela." I hung up and returned to Ethan's bay. He was lying very still, his breathing shallow. "The surgical team is coming to see you," I told him. "We're going to get you taken care of." At 5:15 p.m., a young woman in scrubs appeared at the curtain. She introduced herself as Dr. Nina Torres, third-year surgical resident. "I understand we have a possible appendicitis?" I gave her a concise summary of Ethan's symptoms, timeline, and physical findings. She listened carefully, asked Ethan clarifying questions, and then performed her own examination. Her face grew serious as she palpated his abdomen and elicited the same positive findings I had. "This is definitely concerning for appendicitis," she said. "I'm going to order a CT scan of the abdomen and pelvis with contrast, and I'm going to let Dr. Park know we likely have a surgical case." She looked at me directly. "Just to confirm, you examined him and found rebound tenderness, right iliac fossa pain, and Rovsing's sign?" I nodded. "All positive. I'm a physician myself, trauma surgery background." Torres pulled out her phone and stepped away to make calls. 10 minutes later, transport arrived to take Ethan to radiology. I walked with him, holding his hand as they wheeled the gurney through the corridors. In the CT suite, the technician explained the procedure, started an IV for contrast, and positioned Ethan on the scanner table. The scan took about 15 minutes, and then we were back in Bay 12, waiting for results. At 6:02 p.m., Dr. Torres returned with Dr. Angela Park, a woman in her late 50s with steel-gray hair and the confident bearing of someone who'd spent decades making life-and-death decisions. Park introduced herself and then got straight to the point. "The CT shows acute appendicitis with early signs of perforation. We need to take your son to surgery immediately. The appendix hasn't fully ruptured yet, but it's close, and if we delay, he's at risk for peritonitis, sepsis, and significant complications." Relief and anger fought for dominance in my chest. Relief that Ethan was finally getting proper care, anger that we'd lost 3 critical hours because of Kemp's negligence. "How soon can you get him to the OR?" Park checked her watch. "We have a room available now. I'm going to do the surgery myself. Laparoscopic appendectomy, barring complications. He should be out in about an hour, and if everything goes well, he can go home tomorrow." She turned to Ethan. "You're going to be fine. We're going to take good care of you." Ethan's eyes were glassy with pain and relief. "Thank you." As the surgical team prepared Ethan for transport to the operating room, Dr. Kemp appeared at the bay entrance. He looked at the IV, the surgical team, and then at me with an expression somewhere between surprise and defensiveness. "What's going on here?" "Doctor." Park turned to face him, and I could see the professional courtesy in her tone, but there was steel underneath. "Dr. Kemp, I'm taking Mr. Blackwell to surgery for acute appendicitis with impending perforation. The CT confirmed the diagnosis." Kemp's face reddened. "I didn't order a CT. Who authorized that?" Park's expression hardened. "I did. As chief of surgery, I have the authority to evaluate and treat surgical emergencies. Your patient presented with classic appendicitis symptoms, and your decision to withhold imaging and surgical consultation was inappropriate." Kemp turned to me. "You went around me. You called surgery directly. I met his eyes. My son was being denied appropriate care. Yes, I used my contacts to get him properly evaluated. And it's a good thing I did, because according to Dr. Park, his appendix is about to rupture. If I'd waited for you to take him seriously, he'd be in septic shock by morning. Kemp's face went from red to purple. You have no right to question my medical judgment. I'm the emergency physician, and I determined that imaging wasn't indicated based on my clinical assessment. Park interrupted. Lawrence, your clinical assessment was wrong. The patient had clear peritoneal signs, tachycardia, leukocytosis, and localized pain. Those findings warranted immediate imaging and surgical consultation. The fact that the patient's father had to advocate this aggressively just to get standard care is a serious problem. Kemp looked like he wanted to argue, but Park's authority as chief of surgery clearly outweighed his position. He settled for glaring at me. This isn't over. You interfered with patient care, and I'm going to file a complaint with hospital administration. I kept my voice calm. Please do. And while you're at it, I'll be filing my own complaint about your refusal to properly evaluate and treat a patient with a surgical emergency. I'll also be reporting this incident to the state medical board. That's when Kemp's expression changed. The anger drained away, replaced by something that looked like dawning horror. The medical board? Park glanced at me with sudden understanding. Lawrence, do you know who this is? Kemp shook his head slowly. This is Dr. David Blackwell, head of the state medical board. The color completely left Kemp's face. He opened his mouth, closed it, and then in a strangled whisper said, Dr. Blackwell, I didn't realize he was your son. The moment crystallized everything that was wrong with this situation. Not that Kemp had dismissed and neglected a patient, but that he was only concerned now because that patient had a powerful father. If Ethan had been anyone else, some college kid with no connections, Kemp would have sent him home untreated and felt perfectly justified. The appendix would have ruptured, Ethan would have developed peritonitis, and in a worst-case scenario, he could have died. All because a doctor was too arrogant to listen and too lazy to do a proper workup. I looked at Kemp and felt something cold and final settle in my chest. The fact that you didn't know who I was shouldn't matter. Every patient deserves the same standard of care, regardless of who their parents are. You failed to provide that care, and there will be consequences. Park cut in before Kemp could respond. We need to get your son to surgery. Lawrence, you and I will be having a conversation later. The surgical team wheeled Ethan away, and I followed them as far as the OR waiting area, where Park assured me again that Ethan would be fine, and that she'd update me as soon as the surgery was complete. I sat in the waiting room alone, my hands shaking with residual adrenaline. I pulled out my phone and called my wife, Catherine, who was at a medical conference in San Francisco. She answered immediately. David, is everything okay? I told her everything, trying to keep my voice steady. When I finished, she was silent for a long moment. Is Ethan going to be all right? Her voice was tight with worry. Yes. Dr. Park is an excellent surgeon. They caught it before full rupture. He'll be okay. I heard her exhale. And this doctor who refused to treat him? I looked around the empty waiting room. I'm going to make sure he never does this to another patient. Catherine knew me well enough to hear the resolve in my voice. Do what you need to do. I'm catching the next flight home. I'll be there by midnight. After we hung up, I sat in the quiet waiting room and began making notes on my phone. Timeline of events, Ethan's symptoms, Kemp's responses, the delay in care, the accusation of drug seeking. Every detail would matter when I filed the formal complaint. At 7:18 p.m., Dr. Park emerged from the surgical wing, still in her scrubs. Ethan's out of surgery. Everything went well. The appendix was inflamed and starting to perforate, but we removed it laparoscopically. No complications. He's in recovery now, and you can see him in about 20 minutes. I stood and shook her hand. Thank you. For everything. She nodded. He's a lucky kid to have a father who advocated so hard for him. Most people don't have those resources. That was the problem, wasn't it? Most people didn't. Dr. Park, I need to ask you something. Kemp's behavior today, the dismissiveness, the refusal to order appropriate tests, the accusation of drug seeking without evidence. Is this typical for him? She hesitated, and I could see her weighing professional courtesy against honesty. Finally, she said, Off the record? Yes. I've had multiple cases where patients came up to the surgical floor from the ED with delayed diagnoses because Kemp didn't take their complaints seriously. Appendicitis, cholecystitis, bowel obstructions. He seems to have a particular bias against young male patients, assumes they're drug-seeking or exaggerating. The hospital administration knows about it. There have been patient complaints, but nothing's been done beyond verbal counseling. I felt my jaw tighten. Would you be willing to provide a statement for a medical board investigation? Park met my eyes. Absolutely. This needs to stop before someone dies. I spent the next hour with Ethan in recovery as he woke up from anesthesia, groggy but in significantly less pain now that the infected appendix was gone. When he was alert enough to understand, I told him what was going to happen next. I'm filing a formal complaint against Dr. Kemp with the medical board. The investigation will be thorough, and there will likely be a hearing. You may need to give a statement about what happened. Ethan nodded slowly. Good. He shouldn't be treating patients if he's going to ignore them like that. By 10:30 p.m., Ethan was settled in a regular hospital room, comfortable and stable. Catherine arrived at 11:45 p.m., having caught an emergency flight. She hugged Ethan carefully, mindful of his incisions, and then turned to me. "Tell me what you're going to do." We stepped into the hallway. "I'm going to initiate a full medical board investigation into Dr. Kemp's practice patterns. I'll request his patient records for the past 2 years, interview other patients who've complained, get statements from nursing staff and other physicians. If the pattern is as bad as I suspect, I'll recommend suspension of his license pending a formal hearing." The investigation began the following Monday. I recused myself from direct involvement since it concerned my son, but I assigned the case to Dr. Margaret Finley, the board's senior investigator, who had 30 years of experience in medical oversight. I provided her with my detailed timeline and suggested areas to explore. Over the next 6 weeks, Finley conducted a comprehensive investigation. She reviewed Kemp's patient care records going back 3 years. She interviewed 42 patients who'd filed complaints or had negative outcomes following ED visits, where Kemp was the treating physician. She spoke with nurses, other emergency physicians, and specialists who'd received delayed consults. The pattern that emerged was damning. Kemp had a documented history of dismissing patient complaints, particularly from young adults, women, and minorities. He routinely accused patients of drug seeking without evidence. He delayed or refused appropriate diagnostic testing, apparently to save time or because he'd made snap judgments about patients' credibility. He'd missed diagnoses of appendicitis, ectopic pregnancy, pulmonary embolism, and diabetic ketoacidosis. In at least 12 cases, patients had suffered serious harm because of delayed or inadequate care. The most heartbreaking case Finley uncovered was a 20-year-old woman named Alicia Ramos, who'd come to the ED 8 months earlier with chest pain and shortness of breath. Kemp had diagnosed her with anxiety and sent her home without any cardiac workup. She'd collapsed in her apartment 3 hours later from a massive pulmonary embolism. Her roommate had called 911, and she'd been rushed back to Memorial, where the intensive care team had managed to save her life, but she'd suffered permanent lung damage and would need anticoagulation therapy for the rest of her life. Alicia had filed a complaint with the hospital, but it had been dismissed as a judgment call. When Finley contacted her about the medical board investigation, Alicia broke down crying and said she'd thought no one would ever hold Kemp accountable. Finley also discovered that Memorial General's administration had been aware of Kemp's problematic patterns for at least 2 years. There were internal quality assurance reports documenting his high rate of bounce-backs, patients who returned to the ED within 48 hours with worsening symptoms or complications from missed diagnoses. There were complaints from nursing staff about his dismissive attitude and refusal to listen to their clinical observations. But Memorial had taken minimal action, limited to verbal counseling and one mandatory communication skills workshop that Kemp had attended, but apparently ignored. The medical board's case against Kemp was presented at a formal hearing on a Friday morning in October. The hearing was held in a large conference room at the board headquarters, with a panel of 5 board members, including myself presiding, legal counsel for both sides, and a court reporter documenting everything. Kemp attended with his attorney, a sharp-dressed man named Stuart Chambers, who specialized in defending physicians against disciplinary actions. The proceeding opened with Dr. Finley presenting her investigation findings. She methodically laid out the evidence: 42 patient complaints, 12 cases of documented harm, pattern analysis showing bias in patient assessment, testimony from colleagues about Kemp's resistant attitude toward feedback. She presented Ethan's case as the precipitating incident, but made clear it was part of a much larger pattern. Alicia Ramos testified in person, describing her experience with Kemp, the chest pain he'd dismissed as anxiety, the pulmonary embolism that had nearly killed her, the permanent damage to her lungs. She was composed but emotional, and her testimony was devastating. Several other patients testified as well, each describing similar experiences of being dismissed, accused of faking symptoms, or sent home without appropriate evaluation. Dr. Angela Park testified about the delayed surgical consultations and the cases where Kemp's refusal to involve specialists had resulted in complications. She was careful to be professional, but her message was clear. Kemp's practice patterns were dangerous and had caused patient harm. The nursing staff from Memorial's ED granted anonymity to protect them from retaliation, provided statements about Kemp's behavior. They described him as hostile to input, dismissive of nursing assessments, and resistant to following established protocols. One nurse reported that staff had started keeping informal notes about Kemp's patients, watching them extra carefully because they knew Kemp might miss something serious. Chambers, Kemp's attorney, tried to argue that these were judgment calls made in the fast-paced environment of emergency medicine, that Kemp's decisions were within the standard of care even if outcomes were occasionally poor, that the complaints represented a small fraction of the thousands of patients Kemp had treated successfully. But the sheer volume and consistency of the evidence made his arguments hollow. When Kemp himself testified, he was defensive and unrepentant. He insisted that he'd made appropriate clinical decisions based on the information available at the time. He claimed that patients often exaggerated symptoms to get pain medication. He suggested that the negative outcomes were due to patients not following discharge instructions or delaying their return to the hospital. He showed no insight into his pattern of behavior and no willingness to acknowledge that his approach might need to change. I watched him testify and saw exactly what Park and the nurses had described: arrogance, dismissiveness, a fundamental lack of empathy for the people he was supposed to be helping. At the end of his testimony, I asked him directly, "Dr. Kemp, if you had known that Ethan Blackwell was the son of the head of the medical board, would you have ordered the CT scan sooner?" Chambers objected to the relevance of the question, but I overruled him. This was a medical board hearing, not a court of law, and we had latitude to explore patterns of behavior. Kemp hesitated, then said, "I would have treated him the same way regardless of who his father was." It was the wrong answer, because it revealed his blind spot. He genuinely believed his treatment of Ethan had been appropriate, which meant he saw nothing wrong with the way he dismissed and neglected a patient with acute appendicitis. The hearing concluded after 2 days of testimony. The board panel deliberated for 4 hours before reaching a unanimous decision. Dr. Lawrence Kemp's medical license was suspended immediately pending completion of a comprehensive remediation program. The suspension would last a minimum of 1 year. Kemp was ordered to undergo evaluation by a professional fitness committee to assess his clinical judgment and interpersonal skills. He was required to complete continuing education in patient communication, diagnostic reasoning, and recognition of cognitive biases. He would be subject to supervised practice for 2 years following reinstatement, assuming he completed the remediation, and he was required to pay a fine of $50,000 to cover the costs of the investigation. Additionally, the board issued a formal letter of reprimand to Memorial General Hospital's administration for failing to adequately address known quality and safety concerns. The hospital was required to implement enhanced oversight of ED physicians, establish a formal process for reviewing patient complaints, and provide mandatory training on recognizing and addressing provider bias. The decision was made public, as all medical board disciplinary actions were. The local news picked up the story, and it became a focal point for discussions about patient advocacy, medical arrogance, and the importance of listening to patients regardless of their age, race, or socioeconomic status. Alicia Ramos gave an interview to a healthcare journalist, describing her experience and expressing relief that Kemp had finally been held accountable. Other patients came forward with their own stories, and the narrative that emerged was one of systemic failure, a physician whose dangerous patterns had been enabled by an institution that prioritized staffing over safety. Kemp's attorney filed an appeal of the board's decision, but it was denied. Kemp entered the remediation program, though by all accounts he was resistant and resentful throughout. Memorial General Hospital, facing potential liability from multiple patients harmed by Kemp's care, quietly settled several lawsuits. The hospital's ED director was replaced, and new protocols were implemented to catch early warning signs of provider problems. Ethan recovered fully from his surgery. The incisions healed, and within 3 weeks, he was back at work. But the experience changed him. He became passionate about patient advocacy, started volunteering with a nonprofit that helped people navigate medical systems and file complaints when they received inadequate care. He told me once that the worst part hadn't been the physical pain, but the feeling of being dismissed and not believed, of knowing something was seriously wrong but being treated like he was lying. "If I hadn't been your son," he said, "if I didn't have you to call, I don't know what would have happened. I would have gone home because I wouldn't have known how to fight back, and my appendix would have ruptured, and I could have died." He was right. That was the reality for most patients who encountered physicians like Kemp. They didn't have the knowledge or resources to advocate effectively, so they suffered in silence or worse. 6 months after the hearing, I received a letter from Alicia Ramos. She thanked me for investigating Kemp and holding him accountable. She said that knowing her experience had mattered, that it had contributed to protecting other patients, had helped her begin to process the trauma of what had happened to her. She was back in school, studying to become a patient advocate, inspired by her own experience to help others navigate the healthcare system. I kept that letter in my desk drawer, a reminder of why the work I did at the medical board mattered. It wasn't about punishing physicians for honest mistakes. It was about protecting patients from practitioners who'd lost sight of their fundamental obligation to do no harm. A year after Kemp's suspension, he applied for reinstatement. The fitness committee reported that he'd completed the required training but continued to show limited insight into his behavioral patterns. The committee recommended that he be allowed to return to practice only under strict supervision and with limitations on his patient population. He would not be allowed to work in emergency medicine without a senior physician co-signing all his cases. He would be required to undergo monthly audits of his patient care for 2 years, and he would be subject to immediate resuspension if any new complaints of dismissive or inadequate care emerged. Kemp accepted the conditions, apparently because he had no other choice. He ended up taking a position in urgent care at a small clinic where his practice was closely monitored. I heard through the medical community grapevine that he was bitter about the outcome, that he blamed me personally for destroying his career, that he told anyone who would listen that the whole thing had been a vendetta because of my son. But the truth was simpler and sadder than that. Kemp had destroyed his own career through years of arrogance and negligence. He'd harmed dozens of patients because he'd stopped listening, stopped caring, stopped treating people with dignity and compassion. My son's case had been the catalyst that brought everything to light, but the problems had existed long before Ethan walked into that emergency department. I thought about that often when I reviewed other disciplinary cases. How many physicians were out there practicing with similar blind spots, enabled by institutions that looked the other way? How many patients suffered in silence because they didn't know how to advocate for themselves? The medical profession was supposed to be self-regulating, built on trust and ethical standards. But self-regulation only worked when people were willing to hold each other accountable, to prioritize patient safety over professional courtesy, to acknowledge when someone wasn't fit to practice. 2 years after the initial incident, I was giving a keynote speech at a medical conference about the importance of addressing physician bias and improving patient communication. In the audience was a young doctor who raised her hand during the Q&A session and asked how physicians could better recognize their own biases and assumptions about patients. I thought about Dr. Kemp, about his assumption that young men complaining of pain were drug-seeking, about how that assumption had nearly killed my son and had harmed so many others. The first step, I said, is to remember that every patient who comes through your door is someone's child, someone's parent, someone who matters. When you find yourself making assumptions about a patient based on their age or appearance or how they present their symptoms, stop and ask yourself, would I treat this person differently if they were my family member? If the answer is yes, then you need to reevaluate your approach. After the conference, a physician approached me privately. She was in her early 40s, an internist from a community hospital. "I wanted to thank you for your son's case," she said. "I have a colleague who's been dismissive of patients, and I've been too afraid to say anything because I didn't want to cause problems. But after hearing what happened to your son, I filed a concern with our medical director. They're addressing it now. Your willingness to hold Dr. Kemp accountable gave me the courage to speak up." That conversation stayed with me. The ripple effects of accountability. One case, properly investigated and resolved, could encourage others to speak up, could shift culture, could save lives we'd never know about. Ethan is 28 now, healthy and thriving. He's engaged to a wonderful woman he met through his advocacy work, and they're planning a wedding for next spring. He still has small scars from the laparoscopic surgery, 3 tiny marks on his abdomen that serve as permanent reminders of the day he almost died because a doctor was too arrogant to listen. But he's used that experience to help others. He's become a powerful voice for patient rights, speaks at conferences, writes articles about navigating healthcare systems, and volunteers with organizations that support people dealing with medical negligence. I'm proud of him, not just for surviving, but for taking his trauma and transforming it into something meaningful. Dr. Kemp is still practicing, though in a much diminished capacity. His career will never recover to what it was, and that's appropriate. Some physicians, when confronted with evidence of their failures, take it as an opportunity for growth and change. Others, like Kemp, remain bitter and defensive, unable to see beyond their own ego. I don't waste energy thinking about whether Kemp learned anything from the experience. What matters is that he's being closely monitored, that he can't harm patients the way he used to, and that the system worked the way it was supposed to work. As for me, I continue leading the medical board, investigating complaints, holding physicians accountable, and working to make healthcare safer for everyone. Catherine sometimes asks if I regret using my position and connections to help Ethan that day at the hospital. My answer is always the same. I regret that I had to, that the system failed so badly that it took my intervention to get my son appropriate care. But I don't regret doing it, because every parent should advocate that fiercely for their child, and every patient should receive care as if their parent is head of the medical board, watching, expecting excellence, demanding accountability. The phone call from Ethan that Wednesday afternoon, the fear in his voice, the pain he was enduring while being dismissed and neglected, those memories have stayed with me. They've made me more committed than ever to the work of protecting patients from physicians who've forgotten their oath, their humanity, their purpose. Medicine is a privilege, not a right. The ability to treat patients, to make life and death decisions, to be trusted with people's most vulnerable moments, that's something that must be earned every single day through competence, compassion, and ethical practice. Dr. Kemp forgot that, or maybe he never really understood it in the first place. Either way, his dismissive expression when he walked into that emergency bay and saw me, his whispered realization that he'd made a catastrophic error, not in medical judgment, but in human decency, that moment crystallized everything I'd spent my career fighting against. The assumption that some patients matter more than others, the arrogance that prevents physicians from admitting uncertainty or error, the systemic failures that allow dangerous practitioners to continue harming people. My son survived because I had the knowledge, resources, and position to fight back. But I carry the weight of knowing how many others didn't, how many patients went home undertreated because they couldn't advocate for themselves, how many lives were damaged or lost because someone like Dr. Kemp decided they weren't worth listening to. That's the burden of accountability, the knowledge that even when justice is served, it comes too late for those already harmed. But it also drives the commitment to do better, to fix broken systems, to protect the next patient who walks through those doors, scared and hurting and desperately hoping that someone will care enough to help them. If you made it this far, hit like, you've earned it.